Okay, I think I'll get started. So Dr. Negley just told me we have intern applicants here today, so that's good to know. And for the audience, what I'm going to do is this is going to be interactive. So the good thing is that it's a smaller group, so you're more likely to get called on. Yeah, so you're looking around because you're closer. So the other thing I thought about as I was developing this talk for this morning was really to think about how do we do clinical research? And especially for the junior faculty, how do we think about what those right questions are and how we pursue them, and how do we interdigitate that with our clinical practice? And so, as many of you know, so by the way, for those that don't know me, I'm the director of blood marrow transplantation here at the University of Minnesota. But one of my areas of interest is bone marrow failure syndromes. And so, what I thought I'd do is, rather than talking about the complications of transplant per se, is to really focus on the newly diagnosed patient and particularly how it relates to my own practice. So I'm going to start off with a case history. I'm going to ask you questions along the way because, this is really meant also to be for the generalist, but also for those of you that are specialists in the various areas of pediatric medicine. There's parts of this that could relate to you. And as you know, that we oftentimes will call consultations to asking help from a variety of you in this audience to help us get through caring for these very difficult patients. So I'm going to start off with a case, and then I want you to tell me what you would do next. Just like this is if you were in the clinic and you're seeing a patient for the first time. This could be a story that you see. So actually, there you see in the very top there is a 9-year-old male, happens to be the one on the right, and that happens to be his brother with him, who comes to us with a 1-year history of isolated mild neutropenia. He was followed by his pediatrician for a period of time, and over that time, they were able to determine that there was a slightly low B12, for which then the child was replaced with B12 for a couple of months, but didn't respond. And he was generally healthy. He had about 6 upper respiratory tract infections over the year, but that was just typical. And otherwise was just fine. So now what happens is that the referring physician is now a bit more uncomfortable, like I don't know what the cause of this neutropenia is, and then he refers him to us. So I guess what would you do at that point? Okay, well let me give you one more piece of information because obviously there is a CBC to take a look at, but let's just walk us through this. Beforehand, the other thing is that we also are told is that this is the kind of growth he has. So does this mean anything to you? Tony, you're the endocrinologist in the audience, Yeah, so he's maybe small, but he's not off the charts. So this doesn't give us too much of a hint. I'm sorry? Yep, he is. Yep. And father and mother also on the smaller end, so nothing too unusual. But here's the CBC. So Joe, what strikes you? The MCV. Now, the thing is that for the non-hematologists, oftentimes people only look at the white count, the hemoglobin, and the platelets, and kind of forget the rest of that stuff in the middle. But the MCV is elevated, and so that tells us the size of the cells red cells are a bit larger than what you would have expected for his particular age. Now, the one thing you should also know for the neonatologists in the room, MCVs are different sizes at different ages of life. But overall, this is certainly an elevated MCV. But otherwise, you have a neutrophil count that's 800, a white count that's 2.7, and an elevated MCV. The platelet count is normal. But by the way, I want to show you that this patient also never really had true significant B12 deficiency that would result in any bone marrow manifestations, because these are what his white cells look like. But that's what a B12 deficient white cell would look like, a neutrophil would look like, with these hypersegmented neutrophils. So that probably wasn't never the cause of his neutropenia, but yet it is certainly in the differential of a patient who has isolated neutropenia. So what else do you want to know? Well, the past medical history, the social history, and family medical history. So give me some ideas of what you would want to know. What would you want to know in the past medical history? What kind of things would you be interested in? Someone who has a neutrophil count of 800 and an MCV that's 102. Yes. For the PhD in the audience. Yes. Yeah, history of infections. Well, the only thing that we had was we had the upper respiratory tract infections. And for the pediatricians, is 6 unusual? What's the average number of infections per year? No, you missed it. He's 9.
Oh, a 9-year-old is 6.
Yeah.
Do you go to daycare?
I don't remember, actually.
Because by 9, if you went to daycare and you went to kindergarten, actually by 9, you're pretty solid.
Okay.
I would just, a lot of the time, in the context of otherwise completely normal kid with no leukemia, I wouldn't necessarily look at it.
Yeah, yeah.
But if you're leukopenic, neutropenic, and you have 9, I'd be like, that's
No, he has 6. He's 9, but he has 6. Okay. You think it's a bit too much? For 9. Yeah, okay. Good to know. Okay. But what else would you like to know in this medical history, social history, family medical history? Is there anything else you would want to know? Huh? Okay, Mark. No, he had no thumb surgery. Okay. Okay, well, first off, probably you would be a bit more thoughtful about your... Okay, what else do you want to know about past medical history? Okay, so you asked about surgeries. Are there any surgeries? Right, right. Great. So you want to know more about whether or not this was actually more significant, because sometimes a parent can tell you something that may not be the full story. It could be, yes, upper respiratory tract infections, or people say they have bronchitis, or they'll use terms that really aren't that specific, and you can actually find out there's something more than that. But in this particular case, his past medical history was actually pretty unremarkable overall. But let me give you a bit more information. So, yes, what we want to figure out is what his prenatal history was, early development, immunization history, hospitalizations, surgeries, exposures, school issues, and also anything wrong with the parents, siblings, or extended family. But let me just go back and just say, in terms of, the prenatal history, that sometimes can give us a clue, because one thing that we're trying to figure out is this a congenital disease or is this an acquired disease? So the first thing that we think of is that when you have a neutrophil count that is as low as it is, we're going to be thinking about, is this an acquired abnormality, such as could it be antibodies related? Could this be a drug effect? Could this be, viral disease? I mean, that probably is the most common reason for having a low white count. But, this has actually been going on for now, 6-7 months. And so this is probably not likely a virus as the cause. And in fact, he has no medications that would account for this isolated neutropenia. But then he also we could be asking questions about, what's going on with the family. And as Margie pointed out, is there consanguinity? Well, that's certainly an issue that we want to know of, particularly for patients outside the U.S. that come see us, or those that are in ethnic or racial minorities in the U.S. that might have a higher chance of having consanguinity. But oftentimes that turns out to be a negative answer. But there's other things we want to know about in the family history that might give us a clue. Well, anyway, let me just go a little bit further in giving you some more history. So in the past medical history, mother had, at the time this child was born, was 38 weeks gestation, normal pregnancy, delivery was normal, had neonatal hyperbilirubinemia, but that was the only thing that was abnormal. Today, the immunizations are up to date. As I said, the 6 URIs per year with occasional sinusitis in the history, no hospitalizations or surgeries, wears glasses. That's about all we could find out. So actually, by the way, this is a real story. This is not one that's made up. And there's a series of stories I'll give you, and sometimes they're compilations of several patients that we've had, but this is an example of what we would see. So in terms of social history, mother's a first grade teacher. Father is a gas station owner. What does that do for you? Yes, Joe. Yes, and then it turns out, in the real story here, although I'm not going down this path, he actually has very high levels of toxins because they actually lived over the gas station. And so that was something that was an unusual twist here. But that's a red herring that I want you, I mean, yes, is important. He also had high lead levels. There was a variety of things that were different about this kid, but we're not going to go down that path for the purpose of this discussion today. So that was an interesting thing. Okay, he has 3 siblings. They live in a single-family home. They have a dog, cat, lizard, and turtle. Margie, why do I care about lizards and turtles? Salmonella, so that's one thing we want to know about. Good at school, but struggles with math. Okay, the general pediatricians, probably not too uncommon. So this is not going to tell you what he has. Well, this is what parents tell me. You know, they don't tell me that I can't get too much out of that. Oh, sorry about that. So I think I actually had something written incorrectly before. But anyway, family medical history here is 35 years old, gravida 5, para 4, and had gestational diabetes. So there's something I wrote incorrectly before. So this is the correct family medical history. So there was 1 fetal loss. That was interesting. Father's 38 years healthy, 6-year-old brother healthy, 3-year-old brother healthy, and 2-year-old sister with coarctation. That's interesting. So the cardiologist in the room, what would that tell us? Is there a congenital Marrow syndrome that might be associated with coarctation? The answer is yes. And the patient had been treated here with coarctation. So that was interesting too. And I'll get back to that because I don't want to forget. So remind me to tell you what was in the medical record of that patient with coarctation. So anyway, going back to the patient again, so what we're looking for in terms of infections, we're looking for infectious diseases such as CMV, EBV, influenza, parvovirus as a cause of isolated neutropenia, although remember, it's not really isolated neutropenia any longer because we saw an elevated MCV. We look at drugs, as we talked about, so these are a couple of common drugs that would be associated with neutropenia. We can think about immunologic. So these are things that would be acquired as a cause of transient neutropenia. But then there's chronic issues. We talked about B12 already, but there could be folic acid deficiencies, copper deficiencies, protein deficiencies. And then there's intrinsic causes that would be specific to the hematopoietic stem cell specifically that we'll get into. So what we can tell you is that all these things were normal except for this very low B12. And so this leads us now to the intrinsic causes. So what? Yes, anyone less than 1,500. Okay, and so when he was being followed by the pediatrician, it was always in the 1.0 to 1.2 range. So it was mild neutropenia. And so he felt comfortable just monitoring for a period of time. But then when he makes the referral, it's because it has dipped for one time below 1,000. So now the other referring physician is nervous, like, am I something I'm missing? Now, the MCV was actually borderline. It was at 99 when he was actually following it. And over time, it actually got a bit worse. So none of these things were dramatic changes, yet the trend was going in the wrong direction. And it was also not something that you could blame on just a viral exposure, as would have been the most common etiology of isolated neutropenia, in a pediatric patient. No, I probably would just, it depends how long we've had a chance to follow him. Because if it's just, a couple of time points that are relatively close together, I would probably, check his white count again in about, a couple of weeks to a month and see whether or not it would improve. And the B12, I think was a red herring, but I thought it was perfectly appropriate to actually treat that and see whether or not that would make a difference. At least it eliminated one other cause that it could have been. Okay, so then what we have to now worry about an intrinsic defect. So now we're going to be moving forward now and doing a bone marrow aspirate and seeing whether or not there's anything abnormal in the bone marrow aspirate. So you see 5 to 10% cellularity. So what would you expect, Joe, in a 9-year-old? 5 to 10%, is that low?
That's low.
What would you expect? What would be normal?
30%, 40%, somewhere there.
So something higher. So, when we're first born, we have a very high cellular marrow, but over time there's more fat replacement. So 5 to 10% clearly by everyone's, no matter what your age group, is going to be an abnormal bone marrow. The important thing, there was no dysplasia. There was nothing that looked abnormal in terms of the architecture, or not architecture, but the morphology of the hematopoietic stem cells. And the cytogenetics right now is pending. But then what happens is that we get a surprise call that we find now 2 abnormal clones in the bone marrow. So the bone marrow doesn't look abnormal. In terms, except for cellularity. And I'll show you what some of the abnormal cells could have looked like. But what we have now is we have 2 clones. We have now, a clone that's 45% of the metaphases have a duplication of the long arm of chromosome 1. And we also have a 20q abnormality as clone 2, although this is just showing you what happened in clone 1. So this is interesting. So we now have, a complex cytogenetic abnormality in a child that's 9 years old with a normal bone marrow except for a low cellularity. So this is not something that you would see very frequently. So when you look at the MDS, let's presume that he has MDS or because of the complex cytogenetic abnormality, although he doesn't fit the definition because it doesn't have morphological changes yet. But the chance of him having MDS at this age is really low. So roughly 1 in a million kids would have MDS at that age. So this is unusual, except for specific diseases. So now we're honing down as to what the etiology of this disease is. So before we get into making the diagnosis of what this child has, this is what myelodysplasia would look like. Okay, probably what I should have done for this audience, and I apologize for not having thought of it before now, is to really show you what normal bone marrow looks like. But to give you an idea, you know what megakaryocytes look like, these multinucleated large cells in the bone marrow, where the nuclei are typically overlapping, or all overlapping each other. So seeing something like this is clearly an abnormal megakaryocyte. More frequently in some of these bone marrow failure syndromes, we'll see something like this, where you have where it's a single nucleus or 2 nuclei. That would be pretty common in pediatrics. Now, this is more of the different things that you would see in a typical adult with myelodysplasia. But for children with myelodysplasia, we don't see all of these abnormalities at the same frequency as you would for adults. But nonetheless, the morphology of the cells look very different than what they should have. But this kid doesn't have that. This kid has normal-looking cells, just fewer of them. So, Margie, what would you do next? Oh, Margie, you can't get this wrong. Okay. Yeah, what's the next test?
Well, I think you have to look at, you want to look at other causes for marrow failure beyond what yours.
Okay, so one cause of the marrow failure that we're looking for, so now we're thinking about, because acquired MDS is so uncommon in this age group, we now have to think about congenital causes of MDS and congenital causes of bone marrow failure. Okay, so you have several choices. You have, this could be something like dyskeratosis. It could be Black Van Diemen syndrome. It could be Fanconi Anemia. They would be probably the most likely candidates for this. So what else would you like to find out that I haven't told you yet? So if it was dyskeratosis, what would you want to be asking, Troy? What physical findings would you want to see to help support something like dyskeratosis? Fingernail changes. I'm going to repeat it so you can hear it. So fingernail changes, specifically looking at abnormal nails. Okay, what else? Anything else?
I think sometimes they can have changes in hair texture and skin changes.
So skin, hair changes, that would be characteristic, and sometimes you don't have that. And then, so there's the other soft findings, but now what's going to happen is because of the technology that's available to us now, we can do now more sophisticated molecular tests to be able to tease out which one of these congenital marrow failure syndromes it is. So, Margie, what is the most common congenital marrow failure syndrome?
Well, when you want to test for sure is
Yeah, so you test for Fanconi Anemia. That is the most common congenital marrow failure syndrome. And so therefore, that's an easy test that we want to do, which is DEB, or diapoxybutane testing, and mitomycin C. Okay, so just to summarize what we have already: isolated worsening neutropenia, hypoplastic marrow, complex cytogenetics, no evidence of infection, slightly low B12, less than 10 percentile for weight, no medications or chemical exposures for purpose of the discussion today, although it was not true for this particular case.
John, did you say how tall you are?
Yeah, so I just showed that he was like around the 15th percentile. So he was following his growth curve, so that was okay, and his parents were also like 5'7", 5'8", so they were on the smaller end. Okay, so for many of these, marrow failure syndromes are oftentimes autosomal recessive disease, and this is what it might look like if it were an autosomal recessive disease. In this particular family, there was no medical history of there's no family history of Fanconi anemia. But what he had a history of in the family was basal cell carcinoma, asthma, severe anemia, but in a 95-year-old great-grandmother, and fibromyalgia, hypertension, rheumatoid arthritis, ALS, colitis. So really nothing, there was no cancers, there was no marrow failure, there was no history of transplant for any reason, no leukemias, and there was nothing that really gave us a clue in this. So there really was the pedigree itself didn't help us as it does in some cases. And by the way, mother and father did have consanguinity, but they were very distant relatives to each other. So we've discussed the different causes of the marrow failure syndromes, and we then get the mutagen stress testing. So he does have Fanconi anemia. And this is the characteristic findings. So when the cells are exposed to diapoxybutane at very low doses, for any of us in this room, presumably none of us have Fanconi anemia, that you would not have any spontaneous breaks or breaks in the presence of DEB, which is a chemotherapy type drug. And what it does is it actually, at very low doses, causes these types of breaks that are very specific to Fanconi anemia. For all intents and purposes, this is the diagnosis. You need not do anything else. However, there are a few isolated cases where DEB testing, usually at low levels of positive results, that actually are confused with other types of DNA breakage disorders. But for all intents and purposes, if you get a positive test, you have your diagnosis. But if you get a negative test, it doesn't rule out the diagnosis, and I'll show you why that occurs, but that's also something that doesn't occur very often. So we also repeated with mitomycin C. It gives us also the chromosome breaks. And so this patient has FA. And this is just summarizing what the results look like. So what happens is that if you send this test to Betsy Hirsch, in our cytogenetics lab, you'll get a report that demonstrates, that the patient has this elevated level compared to the control, and then this is the FA range. So we have a positive control to go along with it. So it's clear that this patient has FA. And I'll show you what the actual report is, because when you send this, you have to look at two things, and you may not be used to looking at this, but I'll show you in a bit. So we have a patient with Fanconi anemia, and this is a disease that can affect every organ of the body. So it's not just bone marrow failure that these patients have, because that's part of the disease, and that's often when the diagnosis is made. And in fact, in 75% of the patient is misdiagnosed by the geneticist. It's not until the patient has bone marrow failure that the diagnosis is typically made by the hematologist. But that's changing today, because as more and more people are recognizing that this is part of other types of what are the morphology can overlap with other types of diseases commonly seen, it's now being thought of more frequently. So this is just showing you the percent of abnormalities in various organs. The classic patient is missing a thumb, has a fused kidney, and has bone marrow failure. But in fact, that classic case is actually quite rare. We don't see it that often. Most kids are just small and without any clear other distinct abnormality morphologically. The other thing to keep in and to show you is that this is what the thenar eminence looks like. And oftentimes what you have is you have clinodactyly and you have this flattened thenar eminence. As you can see here, missing that muscle. And you see what a normal would look like. That could be the only manifestation that you have that gives you a clue. The other clue is, elevated MCV is oftentimes, part of the picture, but again, that doesn't rule in or rule out, FA, but it's a clue. But this thumb abnormality, short stature or, being small would be characteristic as well. So as I said, the majority of patients will have bone marrow failure, and it's oftentimes the diagnosis made by the hematologist. And you can see here the frequency of bone marrow failure over age. The majority of patients will have bone marrow failure by the age of 20, but there's quite a few patients that don't have bone marrow failure until much later in life. But you also see here there's a higher incidence of hematologic malignancy, that is leukemia, MDS, solid tumor, and most of the solid tumors are squamous cell carcinoma that I'll get into more a little bit later. But that's beyond the pediatric realm. Those things don't happen very frequently in kids under the age of 18. It's the bone marrow failure syndrome that we face most often. So FA is a complex disorder. There's now 21 genes responsible for this disease. And one of the conundrums that we have for quite a long time is that how come we can have so many genes that play a role in Fanconi anemia and yet give us the same phenotype of bone marrow failure and congenital malformations? Well, to make a long story short, and you don't obviously need to know this level of detail, other than the fact that it's actually something that is quite important, not only just in FA, but it's actually involved in all of DNA repair. So this is a rare disease that has taught us a lot about DNA repair and many other diseases. As you all have heard of this one. This is BRCA2. So the breast cancer gene, which people are now more familiar with, is actually a Fanconi gene. And in fact, we've now seen, which we thought was not something that we thought would be embryogenic lethal, would be a biallelic BRCA2 mutation, because these patients have impaired homologous recombination and should be something that would be incompatible with life, but that turns out not to be the fact, at least in some cases. So in any event, there are three parts to this pathway. You have then the core complex in the very top, which recognizes DNA damage. It activates the D2 pathway, which is shown up here. And this is what then activates the repair mechanism, and these are the repair proteins. The reason for knowing about this is that for the geneticist is that if you have a defect up in here, those patients, there's no risk as far as we know for the carriers of this disease. But these are all cancer-causing genes. So yes, the most famous one is BRCA2, but each one of these is a cancer-causing gene that even in one allele, a carrier status, is associated with risk of cancer. So when we're now thinking about identifying potential donors within the family for hematopoietic stem cell transplantation, we need to know the type of gene defect, not that they're just DEB negative, because we might not want to use a carrier potentially, at least for some of these genes. But we're going to get into that in a bit. So I should tell you that I was actually giving a talk to medical students, and we were getting into DNA repair, so that's why you have a number of these things on the side there. So the one thing we do now is that we actually specifically now do genotyping. This is what the FANC-A gene looks like, or this is the protein, and shows you how this interacts with other genes. But the bottom line is that for this particular case, the patient has 2 mutations, and despite the fact that we do have consanguinity in the family where you would have predicted that it would be the same gene defect, you would expect a homozygous genetic defect, it didn't turn out to be the case in this particular kid. But that was a clue as well, but turned out not to be what we would have expected. And the reason why we want to know about the gene defect is, in some cases, it allows us to predict the future of the child's course, both in terms of cancer, for example, if you had a defect in BRCA1 or BRCA2, or if you or the pace of bone marrow failure. So how does bone marrow failure occur? Well, the reason why bone marrow failure occurs, we at least believe, is that there's this DNA repair defect in Fanconi anemia, and because of accumulating cytogenetic abnormalities, perhaps cryptic, but it could be chromosomal at a greater level, you can see that then that might lead to bone marrow failure. But in addition, what we also know is that these cells are hypersensitive to certain regulatory elements, such as interferon gamma. So one of the beliefs is in Fanconi anemia is that for every time you have a viral exposure and then the normal response is production of interferon gamma, you're actually wiping out part of your stem cell pool. And over time, you can imagine how you end up with virtually nothing. And either because of clonal hematopoiesis going off to bone marrow failure, it can also then result in a genetic defect that is acquired that doesn't kill the cell, but then actually has a proliferative advantage, and then MDS leukemia develops. So why does double-stranded breaks occur in FA? Well, it's because of exposures that we have all the time. Certain viruses are associated with that. Acetaldehydes, which is metabolites of alcohol that we're all exposed to, because it's not just drinking alcohol, it's many of the foods we eat. Things like yogurt, broccoli are high in alcohol content. And these are things that, as they're metabolized, they actually cause DNA damage. And certain drugs, and certainly radiation. And in this particular case, didn't help living over a gas station. So we're not going to get into the cell cycle, so I'll spare you that. So there's certain chromosomal abnormalities that are very common. The one I pointed out for this particular kid, remember he had a chromosome 1 abnormality, but also a 20q minus abnormality. But here are the most common chromosomal abnormalities in Fanconi anemia. Now, chromosome 3 abnormalities are very uncommon generally in the rest of the population. So many of the patients that Joe would see in pediatric oncology and having leukemia, chromosome 3 anomalies would be uncommon. This is more common in FA for some unclear reason, and yet we have to find out. And chromosome 1 is also one of high proportion, but also why chromosome 1, not quite clear. And then monosomy 7, that's a more common, typical abnormality that we see in MDS, leukemia, and other patient populations. But what's different about Fanconi anemia, or at least is one thing that's unique, is that these are patients that typically have very complex cytogenetic abnormalities. And so when we see that in a pediatric age population, but even in older patients presenting with MDS, a very complex abnormality should at least trigger the possibility of FA. Now, the oldest FA patients that we have typically seen are up into the 40s. We don't see many that are beyond that, although I've had one patient that's been in his 50s, but that's uniquely different. And actually, we have a referral coming where there's two FA patients, one 58 and one 65 coming. So there's probably many older patients that were just never previously identified. And we'll talk about that in a bit. But nonetheless, the majority of patients are going to be under the age of 20 at the time of presentation. Yes?
Does it mean that each cell has multiple chromosomal abnormalities, or are there different clones?
No, it typically one or two clones that could be present simultaneously, each with their own abnormality, but those clones typically will progress into becoming more complex. So that you may start off very commonly with a chromosome 1 abnormality, and then it becomes a proportion of those will have 1 in 20. Okay? So it's not, I should point out, when I say there's multiple clones, there's no clones where there's just chromosome 1 and just chromosome 20. What it is that it usually accumulates abnormalities. So you may have some clones that are just chromosome 1, and then other clones that are chromosome 1 minus 20. And it's clonal evolution. So it's evolving into more complex disease. So the treatment for this group of patients is hematopoietic stem cell transplantation. So now that we have a patient that has this complex cytogenetic abnormality, has early signs of bone marrow failure, what we would do is we look for a donor, and as I said, we want to find the right donor. It may be HLA match, but that's an important part. But we oftentimes, at least historically, also identify that potential donor as having Fanconi anemia also. So if you have any child that has Fanconi anemia, all the other siblings need to be tested for FA, no matter how normal they look, no matter how normal the blood counts are, because they still are at risk. 1 quarter of those children each will have a risk of Fanconi anemia. So this particular patient, or this is not really this patient per se, But what you would do is you would go to an unrelated donor if you can't find a sibling, but there are many risks associated with that. Graft failure, excess toxicity. And why would that be? Why would they have excess toxicity compared to all other bone marrow transplant patients? A DNA repair problem. And how do we do transplants? We give total body irradiation, or we give busulfan. All of these things, chemotherapy generally cause DNA damage. That's how we cure them of their underlying disease, is to damage the leukemia cells. But because the entire body of these patients is so hypersensitive to chemotherapy, we've had to develop, the right doses of therapy. But nonetheless, optimally, we would like to get rid of chemotherapy or anything that's genotoxic, because what we're probably doing is causing excessive damage. And even if they survive it, we probably cause damage that perhaps can cause other complications later on. So these are common problems that we have to address. And because of the excess damage, breaking down the mucosal barrier increases the risk of infection. And therefore, they have a higher risk of infection as well. So we have to tackle these clinical problems and address each one perhaps individually. And I'll show you how we're going about doing that. But before I go into the more global discussion about the treatment and really focusing on the disease is really the main purpose of today's discussion, because you're not a bone marrow transplant group of faculty or students. You are here to learn about how you tackle bone marrow failure generally. But let me give you a couple of scenarios that might occur that might be of interest to you. So here's another case where an 8-year-old male came with a history of failure to thrive, but is otherwise healthy. But then all of a sudden we have leukemia. So you've gone from, this is a new patient with leukemia. This would be the classic patient that the doctors in pediatric hematology oncology would see routinely. Previously healthy child now presents with leukemia. And this is showing you what the leukemia cells look like. The bone marrow aspirate reveals that he has myelodysplasia, so morphologically he has what's called refractory anemia with excess blasts. He also has several clones. He now has a chromosome 1 abnormality, chromosome 6, a 3-6 translocation. There's multiple abnormalities in this particular patient. And molecularly he also has high-risk features. Okay, well, what happens next? In the family medical history, you find that his mother died of breast cancer 5 years ago. And then we know her mutation. And so for us now, we now make the diagnosis of, Fanconi anemia related to BRCA2. And so this is really, this is another real case that's occurred. And so we now have no time. So now we're faced with a child with Fanconi anemia. And Joe, if this child didn't have Fanconi anemia, how would you treat a patient with MDS? I mean, would you give chemotherapy? Yeah, you would give chemotherapy. And there's other inhibitors that we could think about today, but we would give chemotherapy. But the problem is, if he has FA, would I want to give him regular doses of chemotherapy, or would I want to modify that? Because a typical patient with Fanconi anemia with leukemia, if we gave chemotherapy, they probably would never recover their counts. Because remember, if I give full dose chemotherapy that I would give to a non-FA patient, it either would kill them or they would never recover. Because their bone marrow is so hypersensitive to the chemotherapy, we'd be left with aplasia forever or for quite a long time. So we need to know what this diagnosis is. So we find out that he has this BRCA2 mutation in at least one allele, but that's all we know. We can't find the other mutation because he now has leukemia. I don't have time to do that genetic analysis. It takes usually about 5 to 6 weeks to get that result. So we send the blood off, we send skin biopsy, but now I've just got to make a guess, okay? And I'm presuming this kid has BRCA2 abnormality. Okay, so now I've got to think about, now, which donor do I want? Okay, now how do I know the donor doesn't have BRCA2? Well, leukemia and bone marrow failure is not typically a manifestation of a single BRCA2 abnormality. We know that the donor's DEB negative. So the BRCA2 is okay if he should have it and be a carrier. So it probably doesn't put the child going through transplant at risk if this sibling's a donor. But then we have to talk about genetic testing in young children. for BRCA2. So this creates a new ethical dilemma, where typically you don't do this type of genetic testing until over the age of 18. So that's another discussion we could have at some point in the future. But the other thing, as I talked about, I said, do I want to give him induction chemotherapy and then proceed to transplant? Well, that's probably not what I want to do if it's a typical FA patient, but actually for BRCA2 we do. But now I don't know what he has. Pre-transplant evaluation is going to be a bit different. Okay, so Margie, if I think he has BRCA2, what would I be looking for before transplant? What else do I look for besides leukemia? What kind of malignancies would I see? So medulloblastoma, they have a high frequency. Wilms tumor. But there's other types of cancers also, but they would be the two principal ones that they could have an early life. And in fact, one of the first patients that Margie and I looked at not only came to us with abnormal blood abnormalities, but also came to us with occult Wilms tumor. So we have to then evaluate these patients a bit differently than we would anybody else. And then post-transplant therapy, we're going to monitor them differently. So one patient that Joe and I took care of, and Margie as well, is a patient that actually had probably most every tumor we could think of. Retinoblastoma, I think it was, also had neuroblastoma, Wilms, and also I think died of adenocarcinoma of the colon, right? Was that the right one?
Yeah, that one had retinoblastoma, neuroblastoma, and died of retinoblastoma.
So can you imagine, one child having all these cancers? So this is work in progress. We're learning about this disease. However, this report that I put out in the literature in the early 2000s, all of a sudden I realized I had 7 patients with biallelic BRCA2. And we didn't know until retrospectively going back and looking and finding out that that's what they had. Because what I did is I went back and said, how many patients have I seen with Fanconi anemia that developed leukemia before the age of 6? And you can see here, compared to the other groups of Fanconi anemia, leukemia does not occur that early. It occurs later in life. So this was a very unique population. So I went back and looked at every patient I had taken care of, historically, even before Margie was here, and knowing, that this might be a risk that they had BRCA2. As it turned out, all of them had BRCA2. So now this became a sort of an urgent issue that we wanted to get into the literature to say, we now have this subtype of Fanconi anemia. If you present early with leukemia, rule out BRCA2. Now, this particular patient is 9, so a little bit older. As it turns out, there are older patients, but we didn't know that at the time. So when I was looking at this patient, thinking, okay, mother has BRCA2, he's a bit old for this, but it's close enough. So we treated him as if he had BRCA2. We gave him a different form of chemotherapy, and as if he had BRCA2. So this is the past medical history. He does have abnormal thumbs. He has an alpha-fetoprotein level of 22.4. Okay, so let me show you about that. So alpha-fetoprotein is something as a marker. It can be a marker of a variety of things. You may have used it, prenatally to evaluate mothers to see if they have a higher risk of certain malformations. But in the context of Fanconi anemia, it seems to be a marker for some unclear reason of Fanconi anemia, but it seems to be particularly high in patients that have BRCA2. And so this is what the results show you. So this is BRCA2 here, and they tend to have very high levels. You see here the majority of patients that happen to be FANC-A mutations or FANC-C, they tend to be a bit more of a larger range, but not as dramatic as the BRCA2 patients. So the level of 22 would fall into this range, so he's not quite the BRCA2 range, but again, this is still work in progress. So as Margie pointed out before, these are the types of tumors we look for in the workup. He doesn't have any of these. So we go ahead and we then treat him with busulfan, which we do for the BRCA2 patients. We give them a more intensive therapy than we do the other FA patients because they seem to be able to tolerate it. And plus they have this more aggressive leukemia than most of our general patients. So I treat him here as if he has BRCA2. We choose the HLA identical brother, and we talked about this already. We do the transplant. He does okay. And then we do the next-gen sequencing for, at least at that point, the 16 available FA genes, and he has FANK-A. He doesn't have BRCA2. But I don't know that at the time. So here I make a clinical decision because we're now in a clinical emergency. I do make the best guess, and fortunately, he tolerated the therapy well. Busulfan is often not well tolerated in other FA patients, so we lucked out in him. But that's the clinical circumstance. You have to do with what you have at the time, and you have to make your best guess. So I wanted to get back to the coarctation issue. Remember in that first patient, but let me bring that into the context of this patient. So this is someone. This is one that the geneticist would see. This is a patient that has multiple congenital abnormalities. And this is like the patient that we have, we oftentimes get, but this is not your classic FA patient, but this is someone that comes fairly frequently, that you would see, oftentimes in the hospital with Wagner manifestations. Our belief is that every patient with Vater syndrome or Wagner should we have FA testing, DEB testing, because this phenotype overlaps so frequently with Fanconi anemia. Now, it's more likely certain types of genotypes of FA that would be associated with this complex abnormality. But the one thing I'm going to go back to in terms of that first patient or patients like this is that what oftentimes happens is that FA might have been thought about, but for example, in the child with coarctation, there was a note in the patient's medical record where the medical student said in the differential diagnosis, Fanconi anemia, but it had never been tested. It was not tested until after the second child, or after the first child, older child, was diagnosed at a subsequent period of time. So it's interesting that people sometimes think of it but don't always follow through with it. But even here, where we see more Fanconi patients than any other place on the entire planet, and yet it had not been tested. People still don't think about it when it's outside the context of what they are doing at the time. What I can tell you is it happens with Vater syndrome as well. We have patients here that have Vater syndrome that were not tested for Fanconi anemia. And the reason being is that they came to this institution labeled with Vater syndrome as if that's the diagnosis and it's been made and it's confirmed. And we just take that on and we start treating the individual repair surgeries that we need to do to repair this child. So just keep in mind that if the child's not been tested for FA, it's something that we should be always considering in someone with these complex abnormalities. Doesn't mean they have it, but the reason why you want to know about it is because of the siblings, the reproductive counseling. If it's Vater or Wagner, it's going to be sporadic in most cases. However, in FA, there's a 1 in 25% chance that all the siblings will have FA, and so you want to do that proper reproductive counseling. And then also be different surveillance for that child, knowing that that child's at higher risk for bone marrow failure. So what test do you want to do next? So we now have this information here. So if the patient's now diagnosed with FA, with these symptoms, what would you do next? Would you do AFP, genotype, HLA typing? And this is all you have. Okay, no one's going to answer? Okay, I'm going to ask the PhD, Angela, what would you do next? Genotyping. You would. And the reason being is that, as I'll show here, is because the distribution of Vater is not uniform across all FA genotypes. And you can see here that higher frequency of renal limb abnormalities in the FA Vater syndrome, Okay, so that's one part of it. There's a skewed distribution within FA. You see BRCA2 again has a more likely chance of having that Vater signature. And so that takes us down a path of further testing that we might want to know about, because clearly this impacts not only the child, but also impacts the parents, at their risk. So they may not have a specific risk of cancer in them, but most often these parents are still young and may still be at risk moving forward. So in any event, that's one of the reasons why you want to do the genotyping. There's also genotype correlations, and we're not going to get into, but you might have a higher incidence of bone marrow failure at an earlier age for certain genotypes, and also poorer survival. As you can see here, these are specific genotypes within the FANC mutations, and these are more typically in the Ashkenazi Jewish population. Excuse me. But one thing I want you to also bring up here is that, as you think about clinical research that we do every day at this institution, and for particularly, as I said in the very beginning, for junior faculty who are thinking about developing a research career, think about the problems that we face. Take the everyday things that you see, in the clinic or on the unit, and start asking yourselves questions. Questions about why does something happen or why does something not happen? So what I mean by that is that why is it that 9% of the patients with FA don't have bone marrow failure syndrome? Isn't that interesting? Why would they not have it, and yet they have the gene mutations that are characteristic of bone marrow failure? So I asked that question, a while back with Arlene Auerbach about 15 years ago, and so we started studying these patients that don't have bone marrow failure. And what we were finding out is that there's patients like this. So this is what a report looks like. And one thing, the reason for bringing this up is that you need to know how to read the report in addition. So the top one, okay, so I have a child that has Fanconi anemia. This is in 1992, by the way, when that first child is diagnosed. So I first arrived here, and in fact, Joe, I think you took care of the first child, and he goes to transplant and dies. But in those days, we didn't know how to do transplants for this disease, and so we've learned a lot since then. But in any event, he dies. I evaluate his HLA-identical brother, because he is now possibly going to be the donor. Turns out that he's a match, but he also has FA. And you can see here shown the DEB-induced breakage is 9.2, so clearly in the FA range, and 10 out of 10 of his cells have the chromosome breaks. But look at his sister. Okay, his sister has this level. Okay, so it's above the FA range. I'm sorry, it's above the control range, but this is the FA range. Does she have FA? Does she not have FA? She doesn't look like she has FA clinically. But look at this. 2 of the 50 cells, okay, remember this is 10 out of 10, 2 of the 50 cells have the chromosomal breaks that you would expect in FA. Okay, so the reason why that first number, patient DEB induced, it's a mean number across all 50 cells, and that's a very low number. But 2 of the cells have the classic breaks. Well, this report, was revised because they didn't normally report this. And so when we started looking at that, this is now the routine report, but it wasn't historically the report we would always see. So you've got to look at this number, but you've got to look at this number, because if this number shows that if you get that result, the patient has FA, no matter what the rest of it shows us. Even if you find one cell that has the chromosome breaks. So you have to know how to read it. So why does that occur? It's because this patient has mosaicism. Okay, let's see. And so this is something that geneticists see in other diseases. Somatic mosaicism is a genetic event that occurs where they've, in quote, spontaneously corrected themselves. Okay, so this is the evaluation on the sister of that first patient. So this is her brother. So incubating the bone marrow cells in mitomycin C. At the first dose, you see that there's complete obliteration of the bone marrow colony forming capacity. And yet look at the sister. She's in the red dotted line. She is resistant to mitomycin C. And she's just like the normal control. So what happened to her? So she has FA. In fact, when I check her skin biopsy, she's completely FA. So I can look at fibroblasts and say that, yes, she's DEB sensitive. And yet her bone marrow is completely clonal. It's derived from a single stem cell. And the way we were able to show that is by certain tests that was shown in here, looking at the clonality. But here's the event that's occurred. So when you actually sequence the gene, we can actually tell you that there was a double crossover event. And so her mutations are on one allele. And so she has spontaneously corrected herself. So in one of her stem cells. So what this shows you is that gene therapy can work. If we can genetically correct even a stem cell and get it back into the patient, it can work. So what I'm trying to tell you is that this idea all came from wondering why the 9% didn't develop bone marrow failure. They still have FA, but just not in the bone marrow compartment. Oh, by the way, so what phase of the cell cycle does this occur? How about the intern applicants? If you've forgotten cell cycles, our cell cycle occurs in prophase. That's when homologous recombination occurs. Didn't no one remember that from medical school? So the one thing we also found is in a second patient of mine, his brother also had FA, but then he has this in-between stage. He has FA cells and he has non-FA cells. He's spontaneously corrected. So he's somewhere in this phase where he's corrected his hematopoietic stem cell compartment, but it's in the phase of competitively repopulating the bone marrow with the normal cells, but still has FA cells. However, during this period of time, his FA cells got myelodysplastic syndrome. So this teaches us something else. We have to get rid of the residual FA cells as quickly as we can, if we can, because they still have the capacity to become leukemia. So yes, you have a normal cell population, spontaneously correction, but we have to get rid of the FA compartment. So this also teaches us something about the future of gene therapy. We have to get rid of the residual FA cells. Well, anyway, to get back in the few minutes we have left, is that all of these diseases in congenital bone marrow failure actually interrelate to one another. So this is just showing you Diamond-Blackfan syndrome, Fanconi anemia, dyskeratosis. These are the three most common bone marrow failure syndrome, congenital bone marrow failure syndromes that we would see here. And these are giving you an idea of the complex gene array with each one. And this gives you an idea of how we can test these molecularly these days and make the diagnosis in the majority of patients. But each of these pathways are actually interdigitated with one another, such that it's not a surprise, I guess, that they have very common manifestations that overlap. Again, this is voice for medical students. So this is how we treat them. But the one thing I want to just end with is that also, in looking at how we started off, so back in the late 1990s, this was the result of bone marrow transplant. If you had a sibling donor, you had a good outcome. We knew how to take care of those patients. But if you had an unrelated donor, you had a very bad outcome. And now we've been able to markedly improve those results over time such that they're more superimposable. But one thing I'm going to show you is that what would happen back in those early days is that parents would get pregnant over and over and over again to be able to have a sibling donor. But what that also meant is they also had fetuses that were testing as FA positive, and many of those would be aborted. But even those that were normal in some cases would be aborted. And the reason why that was occurring was because these parents were so desperately trying to get a donor that they didn't feel they had enough time to help their child. So they would abort the healthy child in order to have the HLA-matched, quote, savior sibling. And that's how this all began, was in FA. So you have this very rare disease that actually not only impacts this idea of how we do bone marrow transplants and understanding the cell cycle, understanding leukemia development, but also it impacts upon much of what we do routinely today. The National Marrow Donor Program was in part developed because of families with Wiskott-Aldrich syndrome and Fanconi anemia that pushed for the development of large registries to help their children. So it's amazing that what rare diseases can do to actually change how we practice medicine. So don't underestimate, what parents will do to save their child. And this is also an example of what they would do to get pregnant over and over again. So all of cord blood transplant began with Fanconi anemia. Because they were getting pregnant and they had prenatal testing, they collected the cord blood and then did the transplant. And this is Matthew Farrow, who was the first patient with a cord blood transplant. This is Eliane Gluckman, who did the first transplant in Paris back in 1988. And then this led to the pre-implantation genetic diagnosis that we do, the Save Your Sibling, but now doing it molecularly so we can guarantee that they have the right outcome of both having a healthy child without FA, but also HLA matched. And these were the two children that we did first, both with Fanconi Anemia FANC-C mutations. It succeeded in Molly, it failed in Henry, but yet changed the way we practiced medicine at that point in time. So this is the results that Margie has published recently in sibling donor transplants. This is now what's happened over time in unrelated donor transplants, where you can see this is where we started off, and you can see with various alterations in the way we gave the chemotherapy, we've had a marked change in survival. But survival still comes at a cost, and there's still things that we need to do differently to be able to help these children. And what I would like to be able to do is to figure out ways that we can reduce this problem of squamous cell carcinoma. Remember, we're still giving them TBI and we're giving them Cytoxan, the two most damaging agents to a child with Fanconi anemia. How do we get rid of those things? So what I'm thinking is that the future for this disease is going to be gene therapy. But the problem is that they have so few hematopoietic stem cells available to us for genetic modification as one major challenge. But the other major challenge is that for this particular disease is that we have to get rid of that FA compartment that remains. How do we not only correct the disease, but how do we get rid of all those disease cells that are still residing in the body? And there's some strategies that may help us do that. But look at this result here. This came back from Paris, their results, because they had the first survivors. This is the risk of head and neck cancer in patients with FA undergoing transplant. This is FA patients without transplant. So yes, there's a very high risk to begin with, but it seems to be higher after transplant and actually occurs more rapidly after transplant. In fact, if you get graft versus host disease, you have a 33-fold greater risk of head and neck cancer. And it's infinity. That means every single patient, or nearly every single patient that gets chronic GVHD gets head and neck cancer after transplant with FA. And that's on top of a baseline of a risk of cancer of 706-fold greater than the average population. So this is just how bad this is a problem. This is one of Margie's patients. You can see with the cancer of the tongue. This happens to be one of my patients that also has a squamous cell carcinoma on the adult side. And you can see that this is how significant this is. And this is now a picture of my patient after surgery. Actually, you can see this is the part that was removed. But what's happening is that these patients have not only one cancer, but they probably are believed to have multiple primaries. So the adult patient that I brought to the medical school class last week when I was actually doing a talk on FA to the medical students, I actually brought this adult patient. And what was interesting, he told a story about how he has now 3 cancers in his mouth, one in the tongue, one in the back of the throat, and one in the upper esophagus. And then he also now has bladder cancer, and he's now 6 years out after his transplant for myelodysplasia. And he says, I feel like I'm being slowly cut away. And that's truth, because we can't give him chemotherapy or radiation to tackle his head and neck cancer. The overall survival rate is 0. And yet he wants us to continue because he has a 10-year-old daughter, he wants to live longer, and he wants us to learn something along that process, even though he knows he will die. Well, in any case, we don't have time to go into the future of all this, but nonetheless, just to say that, we have ideas that we want to move forward. And what we're going to be looking at is other new ways of getting rid of genotoxic therapy, giving antibodies that are directed against the bone marrow microenvironment, perhaps giving interferon, because remember I told you that with every exposure to viruses and interferon, these residual amount of FA cells are exquisitely sensitive to interferon. So there's new strategies that we can move forward and hopefully dramatically change the way we take care of patients today and reduce this risk of cancer later in life. In any event, time is up, but I wanted to give you an idea sort of our story, our roadmap of how we took care of FA over time, and to be able to share with you some of the difficulties in managing patients with Fanconi anemia, and even though it's a very rare disease, how it's probably impacted many things that we do today beyond what you might have guessed. Anyway, thank you for your attention. I'm happy to address any questions. Any questions? Yes.
Comment a little bit more.
That's for the short FA patients, I guess.
Can you comment a little bit more in the mosaicism, and if there's some reversion from like clones, for instance, if patients have more percentage of like good cells versus having DNA cells that are sick, and there's some reversion, like a spontaneous reversion of that.
But what's your question about? The spontaneous reversion occurs in about
In patients with mosaicism.
Spontaneous. So with mosaicism, that is the reversion. So when they're in mosaic, that is because that spontaneous correction in a cell, and so it occur. And as far as I know, we've seen it only occur in the bone marrow the bone marrow compartment, and that's probably because it's a rapidly dividing cell population. But I'm not exactly sure what your other question is. So somatic reversion occurs. We know the mechanisms of how they can potentially occur. It's been seen in other diseases, other immune deficiencies, so it's not an unusual phenomenon. The question is, why does it occur? I don't know the answer. Why does that occur in some patients, not others? I wish we could make it occur in everyone. I just don't know the mechanism. Anything else? Yeah.
Sibling, the first, I had to run out, but the kid you presented first, sibling with the co-arc have FA.
Yes.
Really? Okay.
Yes, and so you stepped out, and in the medical record of that patient,
Yeah, it said that was in the differential.
it was in the medical student's note.
Listen to more. Okay, thank you, John.
So the message is listen to the medical students. Thank you very much.
You have been disconnected from the meeting.